Another barrier is the lack of prognostic or predictive biomarkers that could ultimately identify patients who will derive the greatest benefit from an immunotherapy-based approach. This can allow for unnecessary toxicity in unresponsive patients to be avoided as well. In addition, identifying predictive biomarkers are needed for better management of the expensive healthcare costs, especially saving costs on those patients who are very unlikely to be responsive. Now, before we move on, what are the differences between predictive and prognostic biomarkers? Predictive biomarkers enable selection of patients who will obtain the greatest benefits from a treatment and exclude patients who are unlikely to respond. On the other hand, prognostic biomarkers are predictive of patient outcomes and are therefore not used often for treatment decisions. Currently, researchers are investigating liquid biopsy-based biomarkers, tumor tissue biomarkers, as well as tumor microenvironment biomarkers as potential predictive or prognostic biomarkers. Liquid biopsy biomarkers are those that can be detected in blood, cerebrospinal fluid, and urine of cancer patients, making them great potential predictive biomarkers for monitoring therapy response. For example, plasma proteins such as soluble PD-L1 are considered as important sources of information. A high level of soluble PD-L1 has been shown to be a poor prognosis in the immune checkpoint blockade response. PD-L1 level could also be increased due to other physiological conditions or diseases, and therefore more in-depth studies are needed to define a proper cutoff for the use of soluble PD-L1 as cancer biomarker. In terms of tumor tissue biomarkers, there are genomic and non-genomic factors. For instance, DNA mismatch repair system, a genomic factor, is crucial for genomic integrity and stability of the cells. Therefore, it has been demonstrated that tumors with a deficient DNA mismatch repair system are more sensitive to immune checkpoint blockade therapies. Interestingly, data shows that the deficiency is seen more frequently in early stages of cancer than the metastatic cancers, aiding in the selection of the best time point for the therapy. Tumor microenvironment changes are predicted as prognostic factors correlated with immunological activities involving tumor-infiltrating lymphocytes and tumor-associated immune cells. The localization and density of tumor-infiltrating lymphocytes have actually been shown to be a strong prognostic indicator for selection of responsive patients. Highly sensitive next-generation sequencing is needed to identify genomic mutations, and multidisciplinary teams of expert geneticists, molecular biologists, bioinformaticians, and oncologists will be needed. A consensus on methodological standardization must be reached, and the effects must be studied in large populations.